We're going to go ahead and start. So this is our Rising Star session. This is something new. We didn't do this last year. And what we've done is gotten soon to be 5 outstanding early career faculty rising stars in GU Oncology. Sure, shout out. Yeah, let's go. Thank you, Raina, for the enthusiasm. And we're gonna spend about 40 minutes, about 8 minutes each. We've asked them each to prepare one slide of a trial idea, anything, right? Obviously in GU Oncology, but it could be anything, big, small, and different. One schema slide. They're gonna present it in a minute. And then we've paired them with a faculty member who's then gonna sort of lead the discussion of why'd you choose these endpoints? Is this feasible? Who's paying for the trial? All the practical stuff that we think about from idea in our head to trial for 4 or 5 minutes. And then we'll sort of open it up to the room if people have questions. Hopefully all that takes 8 minutes per person. Times 5 is 40, and then we'll get you to lunch, okay? And I don't remember who's first. These are our rising stars. Maybe we'll go down and introduce. I'll talk slowly. Oh, Pedro.
Sure, thank you. Thank you for being here. I'm Pedro Barata. I'm a GU oncologist at University Hospital Sideman Cancer Center, Case Western Reserve University in Cleveland, Ohio. Go Cleveland.
Yeah. I love it.
Hi, everyone. Stephanie Berg. I'm at Dana-Farber Cancer Institute Link Center for GU Oncology. I'm also an executive officer for the Alliance for Clinical Trials in Oncology. So happy to be here. Go Sox!
And I'm Hamid. I'm incoming faculty at MSKCC.
I'm Amanda Nizam. I'm a genitourinary medical oncologist at Cleveland Clinic. Go Team Cleveland.
Nizam Tawagi. I'm a GU oncologist at University of Illinois. I just finished my first year as faculty, and go Cubs.
There you go. It's bold.
All right, Pedro, you lead us off.
Ooh, this is tough. Okay. So, yeah, because I don't have my glasses, so I'm going to try and make this right. But, okay, perfect session in the morning, right? So the context is, as you saw in the discussion, we're really trying to, we understand in real life that not everybody will probably benefit from lutetium, right? I think that's probably clear by now. And so this is an attempt to kind of take one step to perhaps challenge the concept that, everyone with MCRPC will get it. So we're thinking of, and this was designed or thought of a little bit before PSMA4 press release came out. And so we're thinking, okay, so we're looking at vision, and you got to prove, over standard of care, and then therapy compared to with cabazitaxel. Medians were the same, no difference in OS. Quality of life was better. The hazard ratio favored lutetium. And so with that, those two data sets in mind, we're thinking of, okay, so we have patients with MCRPC who progress on novel hormonal therapies, and initially was also on docetaxel, but I think right now in this design, docetaxel would be optional. There's certainly a number of patients by real world and these data sets that suggest the benefit will be less obvious. Who are they? Well, probably those who are eligible for lutetium PSMA by having, positive PSMA scan at baseline. Right, you only have 1 minute, gotcha. And so, and if you start looking at visual disease, higher tumor burden, as defined as you can see in this slide, or aggressive variant disease, right, or a lower SUV mean, I think those patients are less likely to benefit from lutetium than to chemotherapy. And the reason why, but we don't know that, right? So that's perspective our attempt to answer that question. Why carbocabazi? Because it's a very active regimen. There's prospective phase 2 data out there. Very great job from Anderson and a group. And so that is the thought. So randomizing patients with MCRPC post one novel hormonal therapy, docetaxel being optional to be randomized 1-to-1 fashion to either lutetium standard dose or carbocabazi as it was Explore A1C4 cabazi of 20. The primary endpoint could be PSA responses or rPFS. I personally like a little bit more about rPFS, but then and stratified by HRR, liver mets, and then prior dose yes or no. Those were the proposed stratification factors. And I think the next slide is just like a napkin calculations. Oh, okay, fine. So we're talking, I think, the math was around 200 patients or so, for either PSA 50 or rPFS.
About 3 times longer.
I know, 3 minutes.
But otherwise excellent. Otherwise great. All right, we asked Mike Morris from Memorial to help us out with this.
Sure. I think this is one of the most important questions in advanced disease. That is, which is better, lutetium or cabazitaxel, especially for the docetaxel treated population? But I see you've moved it a little bit earlier for sort of the possibility of the chemo-naive patient population. This was similar to the question that was asked in therapy, also a randomized phase 2 study. I think it's a very, very good idea, and I think that it's actually ready for phase 3. I'm not sure you need a phase 2 trial to give you signal here. I think we should ask this in an actually definitive study. And fortunately, Pedro, there is a cooperative group working on this as a phase 3 study. So I think from a point of view of like mentorship and getting you involved in that, you should talk to Raina and Tom Hope, who are designing a study that looks really similar to this in terms of one arm of actually formally comparing PSMA 617 and cabazitaxel. Great idea. I think you should do it as a definitive trial.
How do you decide? Randomized phase 2, just go into a phase 3. What does that look like?
Well, you have a randomized phase 2 study already with a very similar but not identical patient population. So I'm not sure that you gain more by another highly suggestive trial.
Yeah.
What you might want to do, and what Pedro is trying to do, is load those patients up for higher risk patients, and that's sort of what the design also is of the Alliance proposal, which is taking the poor responders, randomizing them.
Right.
Good idea, Pedro.
Other comments?
You look confused, though. You all right?
No, good.
He's like, what? They stole my idea. Other comments in the room? You can go to a mic if you want, or Petros.
Pedro, great idea, great points by Mike. Great to hear that this trial is on, in the works in the cooperative groups. Just to kind of think about the design, I think it's great that UNORITS in high-risk population. I would argue for minor details, any PSMA PET is probably okay. I was asking Tanya here, does it matter gallium versus PYL? Probably not, and Mike, you can comment too, because there's so much variability, Pedro, you mentioned this before, on which PSMA you use. And then a little bit detail here, cabazitaxel, probably 20 milligrams meter square, maybe adequate. And then the question is, if you allow carbo, does this muddy the water in terms of the performance of the control group? It's a little bit different, versus keeping it in pure with cabazi. And obviously, your primary point is PSA, but as Mike said, if you go for a phase 3 trial, probably power it for overall survival. Go big in that case.
Right.
Just a very quick addition, yes. Visceral metastasis, would you want to confine this to liver metastasis? Like versus lung, soft tissue?
Yeah,
I mean, liver clearly has bad prognostication, at least in my view. So instead of visceral metastasis, I think it may be wise to just focus on liver metastasis.
Right.
You use that in the stratification.
Yeah.
But
For the
I'm just talking about at least one factor. What if there is a small lung nodule, 1 centimeter or 8 millimeter? So lung nodule, we know lung metastasis doesn't behave as poorly as liver metastasis. So I'm just trying to streamline the visceral metastasis better by only including liver metastasis.
So gotcha.
One additional comment. I think you just need to make sure that you'll have equipoise. In terms of what Neeraj is suggesting is make this a really bad population. But for example, if you have liver metastases and you have an SUV mean that's relatively poor, just make sure that you're maintaining equipoise in the randomization. They have to have some possibility of responding to PSMA to make it an actually reasonable randomization.
Right. That makes sense.
So you don't want to make it too tough, right, for a population who ordinarily just use chemotherapy for it.
Let's do one more comment, and then we're going to move on. Sorry, Pedro.
Yeah, can I ask a question?
Yeah.
Is that okay? Okay, yeah. I'm not from a mentorship standpoint, Pedro, but out of curiosity, either for you or for Raina or whoever, wouldn't it be nice if we could do a phase 3 to answer the question and do a prospective randomization in 2 different cohorts based on SUV to actually answer the question? Because there may be subgroups that might do better from one versus the other instead of trying to do an all-comer approach.
Ben, one more time. You want to separate the groups?
SUV mean, kind of, and actually answer large randomized phase 3 patients with SUV mean greater than whatever, randomized to Cabazi or lutetium.
At least the thought in here would just go after the guys with SUV mean lower than 10, right? As one of the one factor. At least one factor, not all of them.
Right,
That's
but what
true.
if they have visceral disease or bone mets or the AVPC signature?
Right.
Because you could hypothesize, and I would hypothesize, that there's going to be a patient population based on an SUV mean that Cabazi is going to outperform lutetium, and then there's going to be SUV mean greater than a certain number where the opposite may be true. And I think if we're going to do a large randomized phase 3 across the country and dedicate those resources, it might be nice to look at that question.
Yeah, I guess, we're trying to be thinking, from a practical perspective, you know what I mean? Like, do we have, how many patients we have for each of one of those groups? So that was kind of the thought, I think is a good thought.
Okay, thanks, Pedro. And I know there's 100 things to talk about. It's impossible to talk about a trial in 8 minutes, but meant to be just big picture. And next, Stephanie's next.
Hi. So I'm sorry. I apologize. I missed yesterday's what happened now concept. So this is actually something
Can you put her slide up in?
Yeah, this is my slide. Oh.
We can't see it though. Yeah.
Oh, okay. So this is just a practical question that I've been discussing with Tony, and we know that there's actually a concept going through right now through GU Steering Committee, but I think it's really important because we know in EV302 there was about 100 patients that really dropped off in the beginning that progressed really quickly, right? So when we see those curves, when Tom presented them, there was a group of patients that really did not respond to EV Pembro. And we know that they're going to likely be getting second-line chemotherapy as a standard of care. So my question, it's not a sexy question, but it's what is the role of avelumab maintenance after chemotherapy for patients receiving EV Pembro? And I would really focus on these early progressor patients. So not the ones that progress after 6 months, 9 months of therapy. We're talking about the ones in after the first few cycles, like really what's going to happen with them next. And I would also incorporate, we talk a lot here regarding ctDNA, looking at that response in terms of chemotherapy. Again, is this post-IO space, depending on when the IO is brought on, what it really means. And I think it's important because we have a lot of current trials right now in metastatic in urothelial cancer. Not only MainCav by Dr. Gupta, we have Dr. Sharmad's study also in SWOG, looking at the role of Ribulin after this. So this space is really unknown in this setting because we just know this is the way it's going to happen for most of us. I'm not sure how much, providers, are they really going to go to another ADC, especially if they had a lot of tox? They might be more comfortable with a chemotherapy-based regimen to think about a broader study, since, I also work for the Alliance and we think about how to sequence things. So that's pretty much it. And I have a bonus slide. Hopefully we can.
Sorry.
I have an animate. It didn't work.
Bonus.
Oh, it didn't work.
Oh, sorry.
So I actually put up a table. It didn't get through of the cost of all these medications. I just want to put it out there. For 48 weeks of EV pembrolizumab, it's over $500,000. So with Dr. Galsky that came in, adding nivolumab in that, it brings the cost for 48 weeks of therapy with using chemo nivolumab maintenance is about $200,000. By just doing Pembro alone, it's about $200,000. But if you do chemotherapy with the Javelin study with avelumab maintenance, it's almost like $150,000. So we're spending so much money on EV Pembro, and it is worth it for many, many people, but there is a group that we have to identify where it is not worth it and they do not respond. So that's kind of the concept I was just discussing here.
Great.
Hopefully that was under a minute. Okay, sorry.
Shilpa is going to discuss Claire. Shilpa, right here. Anybody?
Stephanie, great concept. I was just curious what you thought, IO after IO, what would be the utility of adding avelumab maintenance if somebody progressed on EV Pembro?
Absolutely. I feel like there's been, other studies when you add in chemotherapy, the effect of, if you'd almost think it changes DNA damage response to actually have IO better, you would almost wonder how the biology is changing in the tumor to allow for that and why avelumab maintenance in the first place was so successful. So I don't know if the question in bladder cancer has been truly answered in this method, but someone can correct me if I'm mistaken.
So
I know it's been answered in other things.
Like the CONTACT-03 to prove that IO after IO works or doesn't work?
Right, in a fashion of actually sandwiching a chemotherapy sandwich. I don't know. You tell me.
Stephanie, does it worry you? Because I guess you start with 100% of patients on EV Pembro. And
They
then,
would be, progressors.
and then you probably half of them are going to get Gem-Cis, Gem-Carbo.
I would assume, yes.
Half of those.
Half, and then, right.
And then I guess progression on Gem-Cis, Gem-Carbo is going to be higher than it would be on.
We don't know,
frontline.
but right, it could be, yes.
I think it will
Yes.
be. So let's say that 60% progress on chemotherapy. So you have then 50% to start with, and then 50% of those, you're now at 25%. Would you be better off randomizing at the beginning of platinum therapy? In Javelin, we always talked about that. Now, if you want a positive trial, you're better off randomizing later. for obvious reasons. But if you want to answer a really big important question, maybe you're better off randomizing at the beginning.
Oh, I see.
So you randomize
Got it.
At disease progression after blue rather than randomize after orange.
Got it.
But your trial's less likely to be positive, and you're more likely to show sequencing immune therapy doesn't help.
Doesn't actually make a
But
difference.
that might not be a bad thing.
Right. Thank you.
And just to add this, I work with Steph on this. You don't want to make it more complicated, but one question is, in patients who don't achieve SD, PR, or CR, first of all, we don't know the progression rate, and that's one of the issues, Tom, because who said that the PD rate is 20-30% for GEMCIS after Pembro EV? We only have data in first line. But the question in patients that do not get randomized, the one that have PD, can you think about a different design where you do different things? Can you, randomize them to something else? Think about something different?
Well, you could give SGs to progressors in the US.
That would.
So maybe SG versus SG plus maintenance immuno?
But we also think about we have a really our SWOG study, which is struggling right now. Dr. Sharmad's out of he's looking at eribulin plus gem versus, and you can do SG, all these things, and that's actually having a decent activity. So you always wonder what, again, more doublet chemotherapy is going to from that trial. But again, the accrual has been slow.
Stephanie, one more question regarding the toxicity. Patients who've had enough EV Pembro and have neuropathy, how many do you think will be able to go on platinums after that?
Yeah, you would hope though, because if it's just stopping EV Pembro for toxicity, the SD rate and response rate, it's been really, there's a nice tail for the EV Pembro. So afterwards, it would be something. Is really carbo the best choice of a patient with with that, because we know carbo is not really the best platinum agent for urothelial. So then I would think SG would be appropriate, or a clinical trial.
Stephanie, great concept, very important
Yes.
here.
Yes.
Really, really important. I will quote Dr. Rini, and back in Vail 2013, actually, feasibility is the most important, initial thing. And back to Tom's question, I think the big question is IORI challenge.
Yes,
And
it is.
this is a fantastic idea. We have asked actually the sponsor, Merck Serono, to think about this design. But my thought is the IORI challenge question is broader. How about patients who got adjuvant Nivo or adjuvant Pembro?
Sure.
So broaden
Right,
it
but they
up.
would not be receiving first-line EV Pembro.
Exactly. Any
Correct.
prior IO.
Right.
In a previous neoadjuvant trial, Pembro for NMIBC, in that population, right, would you, if you give them chemotherapy, right, of patients who got, adjuvant Nivo and progress, good chemotherapy, the question would be maintenance in that context in a
Correct.
broader population of patients.
Correct. Yes. Thank you.
Very important question. And there is a trial in the works with trying to get the IORI challenge in cooperative groups.
Yes, exactly. It's in the steering committee now.
Vadim, real
I
quick.
recognize that.
Yeah, and real quick question as well. Great concept. I mean,
Okay.
super relevant. With the anticipation that EV Pembro may move into the perioperative space,
Yes.
would you, and that would be maybe relatively soon, would you include those patients, or?
I think that's a different space because it's a limited amount. Because when I was on EV 103, it was only there was only 3 cycles of EV Pembro that was given, and then there was maintenance EV Pembro. But that's been led to a lot of talks after that in the adjuvant space. But I think that's where you can use we would say it could be included. And it's just almost a different biology you think of, right? Because there's a difference between these are de novo patients versus how they kind of relapse. I'm not answering your question.
But if you have a patient who progresses like shortly after surgery, let's say, or even,
Right.
Arguably it's sort of similar.
You would think, right, because they're exposed.
Sure.
So
Well, just something to think about, because
Yeah.
if this sees the light of day in several years, this would be
Sure.
kind of
Yeah.
super relevant.
All right, thank you,
Absolutely.
Stephanie.
Thank you.
I'm going to be the bad guy and cut everybody off. Anis, you're next. If we
So
can get-
all these vetted concepts going to be trials for sure approved by Alliance, right?
Yeah.
Sure, sound up to me.
Or SWOG or NRG.
Anis, go ahead.
So this is a early concept, sort of addressing the issues that we were discussing earlier in the earlier session about adaptive strategy for lutetium PSMA for metastatic CRPC, but taking kind of an inverse point of view and identifying the suboptimal responders and randomizing them to effective therapy. So the population is metastatic CRPC who have progressed after first-line ARSI, chemo-naive, and the imaging selection similar to vision. Patients receive 2 cycles of standard lutetium PSMA. And then a early interim point is considered, and we could talk about PSA or imaging, as Dr. Shueri and Dr. Morris were alluding to before. The optimal response arm would go and receive 4 further doses of lutetium, and a suboptimal response arm would be switched to standard chemotherapy. And the endpoints I've left open for discussion, perhaps radiographic progression-free survival, but whether this is designed as a non-inferiority concept. Clearly, we need this enriched with correlatives as well. We presented at ASCO this year that the use of a CTC readout at the 12-week mark or post 2 cycles of treatment, where if you clear PSMA-positive CTCs, there's a significant difference in radiographic progression-free survival. So those who have persistent PSMA-positive CTCs after 2 cycles have a very short rPFS compared to those who have cleared it after 2 cycles of treatment. And so that is obviously not ready for prime time, so that's built in as an exploratory interim biomarker. And that's about it.
Great. Well, yes, Tanya, do you have a mic? Perfect.
Yeah, so I think this is a great starting point. There's so much to discuss here, such as what is optimal response, right? How do we gauge that? Because we don't really know. So you could almost design a trial where there's just randomization and you just collect the data prospectively to define what parameters ended up predicting who did better with the switch versus staying on the lutetium, and the endpoint would actually be in your dotted box instead of at the end. I think here, either you might consider moving the randomization only to the suboptimal to continue versus not, if we assume we don't actually know what suboptimal is. Because the optimal response arm, what are we learning here? Or you would maybe think about having adaptive dosing on the optimal response, right? If they've optimally responded, maybe they don't get 4 more doses. So in SWOG, we have this concept of keep it simple, stupid, which I will change to keep it simple, star, and say that, very complicated to try to have 2 different randomizations, but NRG is doing those kinds of trials, right? With intensification based on Decipher versus de-intensification, and maybe the community's ready for these more complex designs, just so that we could learn something from both arms. So those are my thoughts.
I'd just like to add to Tanya what she made. Let's make it simple, add a 3rd arm with the continuation of lutetium.
That makes it simple?
Yeah. So I love this. I think this is exactly what we need in the field. I think to get to the point of keeping it simple, actually PSA is a very, very good surrogate of the good and bad responders in this context. And I think thinking about strategies to de-escalate or switch, we can overlay the imaging, which is absolutely necessary, but we can simplify with PSA. And more than happy to work with Anis and Pedro as we develop our adaptive cooperative group study through the Alliance that's looking at doing this. I love the enthusiasm in the room about this. I think there's a clear need to be doing this, and I think the cooperative groups are really poised to do that. So happy to involve you in the development of those studies.
I did have a question about, from a regulatory point of view, with an interim response biomarker, how that would influence things, like in terms of
I would beg to say that there isn't really a regulatory question here. Lutetium is approved. We'll see what's going to happen in the pre-chemotherapy setting. Cabazitaxel is approved. I think it's just informing us as clinicians how we use these agents that are already there for us in the portfolio. So there isn't this regulatory change in label of any way.
Yeah, as long as you don't change the label, the dosing, or the timing, it's not going to be an issue for billing compliance.
Yeah, agreed. Michael, one more comment?
Usually.
I'm going to say something really direct here.
both of these proposals, which we have tried to develop for years now in the cooperative groups. Last year at this meeting, we were discussing how to get this trial moving, and the year before we were as well. And the reason why that they haven't moved forward is that various review committees, primarily made of medical oncologists, have said that this question that Anis is proposing right now is not important. And now I can say that since I'm not part of that particular process anymore, that everyone here recognizes that this is important, and this may mean that the whole review process needs to change in order to have a more multidisciplinary and informed review process, because we knew that this was important years ago. I think it's taken a while for the medical oncology community to recognize that, but it's really important to get the word out that everyone here thinks that this is an important study, and that because that needs to really infiltrate the whole review process right now, which is still, I think, dominated by a lot of people that don't fully appreciate the subtleties and the nuances. Or what?
Or loud.
Or are loud.
Yes.
Yeah.
Yes.
I mean,
You're
I think the take home is just there's a lot of practicality, right? I mean, they can be great ideas, but it still can take a while, especially in the cooperative group setting. So that was great. Thank you. Appreciate it. We're gonna, let's see, Amanda, you are next. Oh, there you are.
So as we've seen excellent response rates with novel regimens like EV Pembro in the metastatic setting, there is kind of an untapped space in the metastatic bladder cancer setting of oligometastatic disease, which the EAU, ESMO, and ESRO actually put out a kind of consensus definition last month. So if we're affecting more potent chemotherapy delivery with an MMAE payload and combining radiation to the primary if intact and also to metastatic sites, kind of like a Medicure or a cytoshrink paradigm, if we're better able to eradicate micrometastatic disease with powerful systemic regimens like EV Pembro, combine those with radiosensitizing therapy, we may be able to affect more potent radiosensitization of the tumor and eradicate disease in people who may be able to get cure or at least remain off treatment. So ultimately, the goal here would be to do a 20-person pilot to establish safety and feasibility. If this does pan out, and including exploratory endpoints such as ctDNA and the Nectin-4 expression, then to move that to a randomized phase 2. And if that does show improved progression-free survival in a randomized phase 2 with EV, Pembro, and radiation to the primary if intact and to the metastatic sites, then you could take that and try to create a de-escalation trial and allow people to come off of EVs. So.
Great. Petros is going to comment. You can get the mic on.
Amanda, great job and really, really important. I think after the standing ovation we experienced at ESMO, many questions were posted, and Dr. Apollo did a great job outlining the de-escalation question, how much we need to give EV. Stephanie, you made a great point about the cost of treatment and the access to this regimen, and obviously there are toxicity concerns and cost concerns. So there is appetite to de-escalate treatment. So Amanda, I think your trial tries to answer this question. I think I like the idea of keeping it broad and not only with primary tumor inside. I think it's nice to have that flexibility at any time of when you have up to 3 or 4 or 5 metastatic sites. It's up for consensus how far you go. I think it's good to exclude liver mets and CNS mets as you did. I like that you do not have any predominant language about the histology. I think it's good to keep it, again, flexible. In terms of some details here, I think the big question is the escalation. Do we need to continue Pembro EV or can we stop? Can we incorporate circulating tumor DNA as an exploratory endpoint in this feasibility study? And if you have ctDNA clearance, is that the potential signal correlating with long-term outcome. So if you have a ctDNA positive to undetectable, is that correlating with treatment-free survival, quoting Dr. McDermott in RCC? And the other question is, this is obviously safety feasibility, but if that it's a good hit, maybe a little bit larger sample size here to have more confidence, I think will definitely increase the appetite for a definitive phase 3 trial with potential stopping Ivi-Pembro, and based on ctDNA quality of data, incorporate this as an integrated or integral biomarker in a bigger study. The last detail is a safety lead-in is good to have. It's a small study overall. We don't have much data about radiation in the context of EV course, so it's good to have at least a safety lead-in early on to make sure there's no any unexpected toxicity signal. Overall, I'm very excited about this.
Other comments, Peter? Can we get a mic over here? It's coming.
Nice job on this. My only question is, you may be setting yourself up for results that you may not want by including the stable disease patients. Patients who get stable disease on EV-Pembro are going to progress very soon after, in my experience. And so radiating oligometastatic sites might be missing the fact that these patients have micrometastatic disease that's about to explode elsewhere.
And you have plenty of responders.
Can I just, in Alliance, we have A03-2002, which is actually in temporary closure right now, which is looking at platinum refractory, I don't know if you knew about that study, platinum refractory disease under Himanshu Nagar, Cornell, with platinum refractory oligometastatic SBRT in addition with pembrolizumab versus pembrolizumab alone. So we are exploring this question, but it does not have a novel ADC on it. And so that one's actually going to be reopening soon for anyone interested to accrue and open at their site.
Petros, you have another comment?
Great discussion. I think one last comment may be, in that context of oligometastasis, it's great to also think about stage 3 disease, like lymph node positive, but no distant mets, right? These are the people who might potentially get cured with intensification of therapy. So T4B, locally advanced or resectable at stage N2 and 3, stage 3 node positive disease can be included.
One last point about SBRT is that there was recently a paper published with brain mets looking at outcomes with SBRT in patients receiving ADC therapy. And while brain mets aren't systemic metastases, I think we have to be a little careful. If you do it too quickly and do it, you might end up causing more toxicity than you appreciate. And I think we need to explore this a little more. ADCs aren't necessarily interchangeable with every other therapy, and so there probably need to be a little bit of work done. And in the phase 1 study, there were problems with enfortumab and radiation being given too close together. That doesn't mean it can't be done, but I think it needs to be done thoughtfully, and we need a little bit of prelim data. We're doing it practically with these drugs, but we're not doing it systematically, and we're not actually looking at what toxicities might be there that we're not appreciating. So, but I actually think this is a great trial, and I was literally talking about the same design with one of my fellows the other day. So
great.
I'm excited by the idea, but we got to do a little bit of work first.
Yeah, and just to add to that, so there are actually a couple of perioperative trials in bladder sparing therapy in the muscle invasive setting. So actually at our center, Dr. Mian, we just opened the adaptive, the RAD-SG trial, which is looking at sacituzumab govitecan and radiation. And I believe, Vadim, you're doing EV-Pembro in that same space as well. Great. So hopefully we'll learn a little bit from those pilot trials as well.
Awesome. Thanks, Amanda.
Great
All right.
acronym, by the way.
Last
Love
but
your
not
acronym.
least, Creed, you have
Honestly,
6 minutes and
love it.
41 seconds. You're up. As soon as your slide pops up, there you go.
So on the heels of EV-302, as Dr. Berg pointed out, we don't really know what to do in the second-line setting. So we're proposing a multi-arm parallel phase 2 study looking at second-line therapy in EVP refractory disease. And so we're proposing 2 arms, the FGFR wild-type group as well as the FGFR mutant group. And then the FGFR wild-type group, sacituzumab, in this setting, could we expect that it would respond at similar rates as in Trophy U01, around 27%? In terms of investigators' choice of chemotherapy, as mentioned previously, do we think that chemotherapy will still have decent response rates in this setting? How many patients will also still have neuropathy and be eligible for chemotherapy if we mandate it to be platinum-based therapy? And then in the FGFR mutant group, how is erdafitinib going to perform in this setting? We have seen it perform around rates of 40% in multiple settings, but now that this is going to likely become the standard of care, at least in the US, where will we go from here? And then in terms of endpoints, we had discussed response rates, but we could also argue for survival as being a primary endpoint.
Okay. Tom, I think you were gonna.
So I thought it's a lovely trial.
Hold on.
So I think it's a great trial. I feel that it's a really important question. We met, the European group met in the guidelines 2 weeks ago, and a week ago, the date was out. There's no data now in this space, there's none.
Yeah.
So anyone,
Hold on, Tom. I'm sorry.
Oh,
I
that's
don't
okay.
think you're on.
Thank you. Well, you didn't listen. I wasn't very important, I was saying anyway, to be honest. So, this is a data-free zone. We met as a group in the ESMO guidelines group, and we couldn't recommend anything above level 3B evidence, which is really, really weak. In fact, we were level 3, B, C. So anyone who generates data here is going to have an advantage. In the presentation, which I was involved with, I was supposed to talk about subsequent. By that time, I'd fallen to pieces. But actually, the commonest treatment that we did give in post-EV pembro was platinum-based chemotherapy. And that was by far the commonest treatment. And the question here is, would an organization like Gilead want to go against platinum-based chemotherapy in this space? And that's the biggest challenge, because I think it's a really important question. I've just got a feeling that the bar is quite high with platinum-based chemotherapy. And if you were leading the sacituzumab global development program, you might say, this is not the space for us right now. Now, you might say, what about sacituzumab plus another ADC? Because that DAD study looked really nice, but you would say, well, not EV. And so what about DV in HER2 positive patients? So DV plus sacituzumab govitecan versus platinum chemotherapy. And suddenly, I think you've got something which you said, okay, I reckon that might just about work. That would involve 2 big drug companies working together, which is challenging. But then you might find an organization which has 2 ADCs, not necessarily sacituzumab, which are complementary with different targets. And then someone might want to go against platinum-based chemotherapy. And then the other thing is, in the original EV302 design, which we didn't talk about at the time, and I'm happy to, we actually had a third arm. We had chemotherapy plus EV pembro. And the reason we had that arm, it was prior to Jonathan and Jonathan's data and Peter and other people in the room with cohort K and 103. And we thought EV pembro was going to have response rates of 55%, not 70%. And so we thought, could we boost that with a third drug? And the original design was about kind of substituting gemcitabine out and putting EV in. And it only became apparent afterwards that EV was, I think it is the most active drug as a single agent we have in urothelial cancer. And I feel that sacituzumab may not be as, we haven't tested it, I feel it may not be quite as active, but we don't know that yet. And TROPICS-4 is a really important study, because that study, and again, if TROPICS-4 is positive, then I think Gilead might come and say, well, we've got a positive trial, we've got a registration here, we're going to use the drug, and let's look, and we're happy to do this study. And if it's negative, then we're a third-line therapy, and if it's positive, we're a second-line therapy. But I think this is it's a brave study, and there might be a different approach.
Tony?
I have a question about the... Oh. For the FGFR2/3 mutant, you could also have 2 arms of sacituzumab versus, because it'll be interesting to see.
Yeah,
the
my
sequence.
updated slides actually had that, but yes, we thought about that as well as a randomized arm.
No, I want to bring back, I mean, we really hit the ADCs, well here, but the combination we reported from Dana-Farber, where everyone thought it's not combinable, including me. What I told Brad and Guru, it's a bad idea, and voted against it, and I was wrong. And now we have 25 patients published in Annals of Oncology that, yes, we can combine these 2 ADCs. How would you integrate them here? Because the rest of the field, the breast and all that have ADCs, are taking chapter from that. Do you think this was an anomaly, Tom?
I think, so we're going to talk more about that later in the meeting, but I think that something that's happening in urothelial urothelial cancer that's different from breast cancer, which have been using ADCs for 10 years. TDM1 is an relatively old drug now. It's because we felt the bar was so high in urothelial cancer, we've been much more ambitious than some of the other tumor types. And so other tumor types aren't doing ADC doublets, they're not doing immune combinations. But there's been a recent development in the field where Merck, MSD Merck, has gone and bought the rights on 2 really important ADCs, which is, one is a B7H3 targeted ADC, which looks really active, and they've gone into a second HER3 ADC, and clearly they have pembrolizumab, and EV Pembro looks pretty good. And so, you know, if I was a big drug company right now, I'd be saying, maybe there's something active between EV and Pembro, and maybe we bring this second generation of immune therapies and build off pembrolizumab. And so I think there'll be an explosion from that, not just in urothelial cancer, but in a huge number of cancers. And that will include prostate cancer. Anywhere where there's low-hanging fruit with chemotherapy, there's going to be an aggressive attempt to replace that with combinations. And I think they're likely, I don't know, there's a good chance they're going to be successful. I think ADCs can beat docetaxel. I know it's been hard, but it was hard to beat chemotherapy in bladder cancer. And I think we can beat docetaxel chemotherapy in prostate cancer with ADCs as a single agent or in combination. So I think that combination data is really important because it's the first combination data, and that's why we were really keen to put it in Annals of Oncology. It's going to get 1,000 references, I think, or citations. I think it will. I think it'll be really successful because people coming to me at the moment saying, that was really interesting, now let's develop triplets. So I think this is a really important study, and I think urothelial cancer, we need to think about this question very, very carefully. I'm not sure this is exactly the right design, but we have to do a study like this, and we've got to beat platinum chemotherapy because that's going to be the standard.
All right, I think we're going to have to end there for time. Thanks, Karina.